This video will provide a brief introduction into spinal cord injury. We'll talk about some basic pathophysiology and clinical manifestations, but first we're going to do just a really quick review of how the spinal cord works and some main things that you'll need to understand for spinal cord injury to make sense. Before we jump into the complexities of spinal cord injury, let's remind ourselves of a few important things about the spinal cord itself and some of its related functions. So beginning with some fundamental anatomy, remember there's 5 sections of the spinal cord as we move down. So beginning from the top, there are 8 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar vertebrae, and 5 sacral vertebrae, and then a coccyx. And now it's important to consider the nerve innervation at specific levels as well. So for example, nerves in our cervical spine innervate important muscles like our diaphragm. Now, if we think about our spinal cord, it extends quite a long way and carries a lot of responsibility for sending along neurological impulses. Some that travel just along a reflex arc, so maybe like our patellar reflex, we tap that patellar tendon, that stimulus sends a signal from the kneecap to the spinal cord, and then a motor response signal is sent back out, causing the leg to extend. But other signals go all the way back up to the brain. So let's say you're driving to class and suddenly you get the urge to urinate. And in order to hold that urine in until there's a bathroom available, that requires communication all the way back up to the brain. And that signal travels from those stretch receptors in the bladder all the way up to the brain and back down to that external sphincter saying, stay closed, there's no bathroom yet. Now, these are just 2 very simple examples of a very long list of different routes that nervous impulses can take using specific parts of the spinal cord. Another thing to consider is that the spinal column isn't just one single tube, right? There are multiple tracks within the spinal column. Some signals go down in a sense. Those descending tracks, also known as efferent pathways, are motor pathways. And motor means movement, right? So these descending pathways, maybe if we look at the anterior corticospinal tract, that's an efferent or descending motor pathway, and it actually can help with movement and control of muscles in our core. Now, the tracks that go up to the brain or ascend, those afferent pathways are sensory tracks. And think of this as receiving information and sending it to the brain. We're sensing a signal. So an example of that would be the lateral spinothalamic tract, which helps us sense pain, temperature, and coarse touch. Now, one more review of our central nervous system, our brain and our spinal cord, that is important to remember when we take care of patients with spinal cord injury is that autonomic nervous system. So for the autonomic nervous system to work appropriately, we need an intact spinal cord. And this is something you've already learned about, but a refresher can help us understand some of the symptoms we might see in our patients with a spinal cord injury. So remember, the autonomic nervous system includes our sympathetic nervous system and our parasympathetic nervous system. So our sympathetic or our fight or flight response is going to lead to all things we would need to fight or to flight. So our heart rate increases, contractility of our heart increases, our blood pressure increases. We even see glucose being released from the liver to help with our muscle and brain function. Even our pupils dilate in fight or flight because we need to take a lot of light in to see what we're doing. We don't need to and we don't have time to digest when we are in fight or flight scenarios. So we'll hear slower bowel sounds and inhibited digestion. And then in our parasympathetic nervous system, we're resting and digesting, or sometimes termed feed and breed. So we're less worried about running away or fighting. Our pupils start to constrict. Our heart rate and contractility decreases. We now have time to digest. We have time to urinate. Blood flow to our reproductive organs also increases. So again, this is all a review, but it can help to remember these concepts as we look at our patients and how they may present when specific components of these systems are disrupted due to spinal cord injury. Specifically, for example, higher level spinal cord injuries at T6 and above are associated with sympathetic nervous system dysfunction. So we'll get into what that might look like later on when we really dig into spinal cord injury. So as we're reminded of some of the very basic functions of the spinal cord, you can imagine how spinal cord injury can have serious consequences for our patients. The level of the injury will affect how signals might get interrupted, and the extent of the injury, so maybe complete injury or an incomplete injury, will also present differently. Did it affect our lateral spinothalamic tract, for example? Our patient may then not be able to feel pain, temperature, or coarse touch below the level of the injury. Were some of the descending or efferent tracts damaged? What kinds of muscles are innervated at those levels of the spinal cord? And now what motor function might be affected? So you can see how complicated this can become. But to start, let's make sure we understand some basic definitions. So the term spinal cord injury is pretty self-explanatory. We have injury to the spinal cord, but it's important to think about how this could happen and the many ways this could present. So spinal cord injury can happen from trauma or an accident, which is really the most common cause of spinal cord injury, but they can also occur for other reasons that you may not be thinking of right away, such as cancer that metastasized to the spinal column. Now, spinal cord injuries are most common in young adult males age 16 to 30, but we're seeing them more and more in older adults as older adults are more active, and we're also seeing people live longer with spinal cord injury as our treatments and our therapies really advance. Now, another important consideration is that some spinal cord injuries cause permanent damage and others cause temporary damage. And just as I was alluding to, some spinal cord injuries are complete, where the whole spinal cord is affected, and others are incomplete, only affecting specific parts of the spinal column. Let's take a closer look at what happens when the spinal cord is damaged. How does the body respond to this injury? Well, as with any injury, the body responds to a spinal cord injury with an inflammatory response. And this inflammation then causes spinal cord edema. And as that swelling builds, it starts to spread. And in addition, there are these tiny hemorrhages that occur in the gray and white matter in the spinal cord, and that just increases the swelling more. So as the swelling grows, it doesn't spread out necessarily, it spreads down and up. So imagine squeezing a tube of toothpaste right in the middle. The toothpaste is going to redistribute above and below your hand. And this is where we start to see more potential for complications. So some terminology to highlight here. The primary injury is what caused the actual spinal cord injury. Maybe they fell off a horse, maybe a motor vehicle crash, etc. However, the primary injury can lead to a secondary injury. And secondary injury is damage that is caused after the primary injury. So let's say you're taking care of a patient who suffered a fall and has a spinal cord injury at T5. That's the primary injury. However, the swelling that occurred after the initial injury is now increasing, and it started to put pressure on the spinal cord, and that pressure starts to spread up and down from the spinal cord injury, from the primary injury. All of that swelling and increased pressure starts to reduce blood flow to the spinal cord. That's key to understand, that this swelling compresses and causes reduced blood flow. And that's a problem because, as we all know, blood flow is important for tissues to survive. And if they don't get it, then the tissue can become ischemic. So this swelling can lead to tissue ischemia in the spinal column, leading to degeneration of those axons and failure of those neurons. Ultimately, if we do nothing and we can't reverse it, it can ultimately cause neuron death and even permanent loss of function. And this can even extend up or down from the primary injury. So you had a patient with a T5's primary injury, but a secondary injury might cause damage up to T4, for example. So this concept of secondary injury is really serious, right? When we're caring for someone in the ED or in the ICU, for example, we can't go back in time necessarily and prevent the car crash right now. We're here with this patient who's already suffered a primary injury. We can't prevent that primary injury right now when we're already taking care of that patient. But what we can do something about is preventing secondary injury. We can at least prevent or minimize more damage from being done that could be due to bleeding or swelling or ischemia or cell death. Now, looking at our patients and what they may look like when they've suffered from a spinal cord injury, we're going to focus on that acute phase right now. How might your patient look right after they've suffered from that accident? How might they look when you're taking care of them in the ICU or in the ED, for example? So one thing that can happen is something called spinal shock. And this very commonly happens in our patients right after spinal cord injury. But keep in mind, it's not going to happen 100% of the time. Spinal shock usually lasts up to 4 to 6 weeks, sometimes taking up to 2 months to resolve. So what is it and what does it look like? Well, it's not the shock that you may have learned about before, like hypovolemic shock or septic shock, where we have systemic hypoperfusion and low blood pressure and so on. Spinal shock is actually characterized by loss of or decrease in reflexes, motor function, and sensory function below the level of the injury. So maybe my patient has a T5 spinal cord injury. In those weeks after the injury, if my patient has spinal shock, they'll not be able to move anything or have limited movement of anything below T5. So that would mean control of their trunk and their legs. They also won't be able to feel someone touching those areas. Also, if they were to have their patellar reflexes tested, for example, that innervation is below T5, so they may not have a patellar reflex. or it might be really diminished. So motor, sensory, and reflexes are diminished or gone below the level of the injury. That's spinal shock. Now, why is this important? Well, if your patient's in spinal shock, how will they look? Maybe they can't move their legs. Maybe they don't have a patellar reflex, and maybe they can't feel you touch their toes. Is this going to only last a month or two, or is this how they're going to be for the rest of their lives? We may not know. Spinal shock can mask how a patient is actually going to look and the severity of their injury. Now, depending on the extent of the injury, some imaging might make it obvious that this patient has a complete spinal cord injury, but in some cases, we just don't know until the spinal shock has resolved. Another thing to consider is how serious is spinal shock? Is it an emergency? Well, that depends in the case of our patient with the T5 spinal cord injury, for example. How much of an emergency is it that they can't walk? Well, if we can keep them safe and support them psychologically and with what they've just gone through and they're stable otherwise, then this is not necessarily an emergency. However, if we have a patient with a C3 spinal cord injury, for example, and they're in spinal shock, that could definitely be an emergency. And why is that? Well, if they lose motor, sensory, and reflexes below the level of this injury at C3, that includes their ability to move respiratory muscles now and to produce an effective cough. That's the A and B of our ABCs. They may not be able to protect their airway or clear their airway. They will not be able to breathe effectively. Now, spinal shock is an emergency because it's at such a high level. And this patient with a C3 spinal cord injury and spinal shock needs to be intubated and mechanically ventilated. So what's something else we might see in our patients with spinal cord injury in this acute phase? Well, in addition to potential spinal shock, which remember can happen if our patient has a C3 spinal cord injury or an L3 spinal cord injury, regardless of the location of the spinal cord injury, spinal shock can happen to our patients. However, another condition can happen called neurogenic shock, and this can actually only happen in patients with a higher spinal cord injury. So if someone has a T6 injury or anything higher than that, so any cervical spinal cord injury and any spinal cord injury from T1 to T6. Now, this type of shock is maybe the shock that you're more accustomed to. So neurogenic shock is a type of distributive shock that results in systemic hypoperfusion. Neurogenic shock causes systemic hypoperfusion because the spinal cord injury led to loss of sympathetic input. So think of it as losing some key components of our sympathetic nervous system. Remember, sympathetic nervous responses would cause tachycardia and hypertension and increased contractility and so on. If a spinal cord injury has disrupted that sympathetic nervous system, we see the opposite. We see bradycardia and hypotension. Now, what is causing that hypotension? Well, rather than peripheral vasoconstriction that happens in the sympathetic response when we're redirecting blood to our most important organs in an emergency, so away from our fingers and toes, for example, in neurogenic shock, we see peripheral vasodilation. We've lost that sympathetic tone, so our peripheral blood vessels start to dilate and our blood pressure drops. And the container for our blood, that's essentially gotten bigger, so our blood vessels have widened, have gotten bigger, so blood pressure decreases, and therefore our ability to get blood to our tissues decreases too. Now, this is definitely an emergency because we have hypotension and bradycardia, and we have big potential for tissue and organ damage. So what do we do for these patients? Well, to treat bradycardia, we can give atropine, and to treat massive vasodilation, we can give vasopressors like norepinephrine, for example. And keep in mind, we may also see hypothermia because that vasodilation will allow our patients to lose a lot of heat. And so when we touch their skin, they might actually be warm at first because we have all of this blood flow to the periphery. So just to recap, spinal shock can happen anywhere along the spine, and if it's at a higher level injury, that involves the patient's ability to breathe, and it's an emergency. Neurogenic shock can only happen if we have a high level injury, T6 or above, and it's always an emergency because our patient is hypotensive and bradycardic. So if you think about it, a patient with a C4 spinal cord injury, for example, could be in real trouble because spinal shock could prevent their ability to breathe effectively, and neurogenic shock could prevent their ability to perfuse their tissues effectively. So the last thing we'll discuss here is whether injuries are complete or incomplete. And this is again pretty self-explanatory, but it's important to look at the complexity of what an incomplete lesion is. So a complete lesion is total and permanent loss of motor and sensory function below the level of the injury. So if I have a T1 spinal cord injury, I'm going to have total loss of motor function below that level, and I'm also not going to be able to feel anything in my legs, for example. And that's going to be permanent. Now, when we talk about an incomplete lesion, think about looking at a cross-section of the spinal cord and how certain parts of it might be damaged, but other parts might be okay. So we're sparing maybe some motor and maybe some sensory function below the level of the injury. Now, as you can imagine, there's a lot of different ways different parts of the spinal cord could be damaged and other ones are spared. So based on the type of damage that there is to the spinal cord and based on which tracks are effective, we're going to see different symptoms in our patients. And we call these syndromes. So different syndromes are going to describe which functions are preserved and which functions are lost. So for example, posterior cord syndrome is going to lead to our patients losing proprioception, so their ability to sense where they are in space. Their ability to feel pain will be lost, temperature and sensation, but they'll still be able to move below the level of the injury. And a lot of times when people don't really think about the cross-section of the spinal cord, it seems really bizarre that somebody can feel but they can't move. But you can think back to that cross-section of the spinal cord and realize, well, depending on the tracks that are affected, certain areas will be preserved and certain areas will be lost.